Thank you, everybody, for coming to the Causal Inference Mini-Symposium for the Biostart Methods Core. This is the last one of the academic year for the Mini-Symposium. We're going to start up again in the fall, and then we will be putting out a survey to the CFAR investigators out there, essentially to identify new topics and new ideas. So once that comes around, please give us your responses and your feedback, and that'd be greatly appreciated. So today we're talking about causal inference, and it was one of the topics that were on the survey that we gave last year. So we're really excited to have a great panel. So Betsy Ogburn is going to be our moderator, and she is in our Department of Biostatistics, and she's an expert in causal inference. And so, enjoy this little symposium and ask good questions.
Thanks for organizing this, and I'm pleased to be a part of it. So I'm just going to give a very broad overview to some of the challenges of inferring causal relationships, specifically from observational data as opposed to experimental data. So you can't have a discussion of causal inference without showing this cartoon. We all know the maxim that association is not causation, and I think people have gotten pretty good about putting the requisite caveats into published papers. But if you really interrogate yourself, I think we all also will admit that we interpret associations causally, even when they're presented with caveats, and that really the underlying goal, even if researchers aren't explicit about it, of almost all research, especially in public health, is to learn about causal association specifically. But of course, association is not causation. So what are some of the reasons that we could see a statistically significant association between obesity and diabetes? It could be that obesity causes diabetes. It could be that diabetes causes obesity. It could be that there's some confounder, some cause, for example, genetics of both obesity and diabetes. Or it could be this last picture, which is an example of a certain type of selection bias that's responsible for a lot of the so-called paradoxes in the health literature. So the obesity paradox is that studies found a protective effect of obesity among diabetics. And one possible, so you could possibly think of a causal explanation for that, but there are many other explanations that would be not causal. And one of them in particular, for example, older populations, would be that if you condition on people who are still alive at an advanced age and have both obesity and diabetes, since those are both independent risk factors for mortality, conditioning on people who are still alive at an advanced age might give you a particularly robust population. And so in that population, you would see that people who have both obesity and diabetes and have survived for a long time have some other extra factor that's making them look like the diabetes is protective. So really simple questions in causal inference, like does X cause Y? Does diabetes have a protective effect among diabetics, or does hormone replacement therapy cause coronary heart disease, can be really difficult. So the HRT and coronary heart disease case got a lot of attention in the media. So for a long time, HRT was recommended to protect postmenopausal women against heart disease, and there were a bunch of observational studies that backed up this hypothesis. And then along comes a randomized trial that shows that, in fact, there's no benefit and maybe even some increased risk of coronary heart disease for women taking HRT. And some causal inference experts went back and reanalyzed the original observational studies and found that they could replicate this new result that contraindicated hormone replacement therapy. So some of the reasons that these really simple does X cause Y questions can be complicated include confounding, unmeasured confounding, measurement error, small sample sizes, missing data, and even just formulating the questions can be really hard. So does hormone replacement therapy cause coronary heart disease? Sounds like a question you might be able to go out and answer, but in fact, it's not very well posed yet. We don't know what population we're talking about. Are we talking about older women or younger women, postmenopausal, premenopausal? What dose of HRT are we thinking about? How long would you have to be on HRT for you to count as a treated individual? If a patient's prescribed HRT but then frequently forgets to take it or stops taking it after a period of time, do you count them as treated or untreated? Are we defining coronary heart disease as during the time that they're on HRT or any time after they start HRT? So there are tons of questions that go into, or a ton of details that go into posing a well-defined causal question. But of course, there are hard questions that are even harder than these simple does X cause Y questions. I'm listing a bunch of them here, but I'm going to focus on longitudinal data with time-varying confounders, and I think the other speakers are also. But I'll just mention that for reference, if these come up in your research, that you can come talk to the causal inference group about mediation, which is by what mechanism or by what pathway does X cause Y. Networks of interconnected subjects, so for example, transmission networks for the HIV world pose a lot of problems that are unique to the fact that my treatment might affect my sexual partner's outcome. There are some techniques to deal with cases where we know that we haven't been able to measure all of the relevant confounders. And then generalizability or transportability, which is the idea that you've estimated an effect in one population, but what you really care about is a different population, a non-clinical population, or moving to a different type of healthcare setting, or a different country, different region of the world, and there are some techniques that can help with that, but these are all big and partly open challenges. Okay, so I just want to talk a little bit about the challenges of time-varying confounders. So longitudinal observational data is one of the canonical settings where you can't just use standard statistical models to get causal effects. And that's because so suppose that we're interested in the overall effect of antiretroviral therapy on CD4 count or progression from HIV to AIDS, or some outcome that occurs at the end of a long stream of doctor's visits and treatment decisions. So in this case, I've got ART at time 0, then we have an intermediate visit where the doctor measures CD4 count and then makes a new decision about ART, and then we're interested in CD4 count at the end of follow-up. So if we're interested in not just the effect of ART at a single time point, but the effect of a cumulative decision of treating or not treating with ART over time, then we have to worry about time-varying confounders. In this case, this intermediate CD4 variable is a confounder for the effect of ART at time 1 on CD4 at the end of follow-up, which means that we have to control for it if we want to capture this part of the effect of ART. If we want the joint effect of ART at time 0 and time 1, we need to be able to get the part of the effect that's through ART at time 1, and that's confounded by this variable. So you might say, okay, great, we'll just throw it into the regression model like we do with all confounders. The problem with these time-varying confounders is that it's also a mediator. So we're also interested in the effect of ART at time 0 on CD4 count at the end of follow-up. And part of that effect goes through this variable. So if we just throw this variable into a regression model and condition on it, we're essentially subtracting off part of the effect of the initial ART treatment decision. I'll just mention that the next speakers are going to talk about some of the strategies that causal inference practitioners have developed for dealing with this type of setting where you can't just throw your variables into it. There's no regression model, no standard regression model that you can throw your variables into and get the right causal estimate out of. And then I'll just close with a quick note on variance and other sources of uncertainty. So when we're interested in learning about causal effects, there are two sources of uncertainty. The first is just that you're going to do some statistical procedure to get at an an association, and there's statistical uncertainty around that procedure. But then there's the extra layer of all the assumptions that you need to make in order to move from an association to inferring a causal relationship. So there's uncertainty about whether it's true that there's no unmeasured confounding, whether it's the case that any dropout was uninformative. There's a whole host of assumptions, and the other speakers will talk about these, that can introduce this sort of meta uncertainty into your analysis. If the assumptions don't hold, then you might have a really great estimate of an association, but it's not causal. So in conclusion, we can use standard statistical models to estimate relationships, but in order to know that the relationships, or in order to have some kind of confidence and reason to believe that those relationships are causal and are meaningful in the way that we want them to be meaningful, we have to worry a lot about assumptions. And I don't know that any of the speakers will hit on this, but we can talk about it at the end during the discussion that the way to assess whether these assumptions hold is through sensitivity analyses, where essentially you pretend that your assumptions don't hold. So you pretend, for example, that there's an unmeasured confounder that you weren't able to collect and that you didn't control for. And then you ask, under what circumstances would this negate the conclusions that I was able to draw from my study? And I'll turn it over to Katie.
It's in the extended mode, just go to that other monitor and do the duplicate. Okay, so thanks Betsy for covering a lot of ground that I don't have to cover. So I'm going to assume now that we're all on the same page, that we're in this setting where we have time-varying exposures, or time-varying confounding affected by prior exposure. So we're going to need to use some methods that fall under this class of methods called G methods, rather than a standard regression model. And I'm going to extend one of the points that Betsy hit on about it's hard to define your question, to talk about intervention effects. And then I'll walk you through the same research question with actually two different G methods, inverse probability weighting and the parametric G formula. Is it safe to assume that most people have at least heard of inverse probability weighting or seen it, sort of some idea of it, and then I'm assuming that the G formula is something that is much less, there are relatively few examples of it in the literature, so I'll spend a little bit more time on that. Just my goals for you today is to kind of walk away with a bit more awareness of the contrasts that we might like to estimate versus the contrasts that we tend to estimate. And then a little bit better understanding of the G formula in particular. The example that I'm going to use to walk through this is the example of ART and depression in people with HIV, right? So in the modern ART era, we have ART that is incredibly effective at reducing morbidity and mortality in people with HIV. And the impact of comorbidities is often sort of the bigger driver of health outcomes. Depression is one of the most common comorbidities in people with HIV, at least in the US. And we have this idea that depression and ART might interact to reduce or influence the risk of mortality jointly. That is, you can imagine a scenario in which a person who is depressed and on ART may be less adherent, and the effect of ART with depression, when the depression is present, is less than if the depression were not present. And then if a person who is depressed initiates ART, they might experience some alleviation of their depressive symptoms because they feel like they're doing something to improve their health. Or alternatively, you could hypothesize that they actually might experience more depression because they're sort of having to face the reality of their infection, or they'll feel more stigma by going to the pharmacy. So we're asking about these two exposures jointly. The two examples that I'm going to walk through because I'm not going to obviously be able to give you the full details are in these two papers. The first one, the Jonathan Todd paper in AJE, is the inverse probability weighted example, and then the G formula is the Annals of Epi paper. So for both, so Jonathan was a colleague of mine when I was in grad school, and we worked together on both of these analyses. And I think they go together nicely to sort of contrast the two approaches. For both analyses, we use a sample of HIV-positive women in the WISE, Women's Interagency HIV Study, who were ART naive at their first study visit after April 1998, which we took to be the start of the modern ART era. And we're looking at 5-year all-cause mortality as our outcome. And so in the sort of first pass with inverse probability weighting, we asked what are the joint effects of depression and ART on mortality. And here the treatment arms or the treatment exposures are either always versus never be depressed, and immediately versus never initiate ART over that 5-year period. So if we think about using observational data to emulate a randomized trial, albeit one that we would never actually do because it would be unethical, you would at baseline do a factorial randomization to either depression, yes, no, or ART, yes, no, and follow people from there. And this might seem a little silly, but this is actually sort of the most common, arguably the most common exposure contrasts that we estimate with inverse probability weighting, or that we're trying to estimate even with standard regression models. And so to put this into picture form, if that's easier, so we have some population in which some percentage of the people have exposure, so I'm using exposed to be green, right? So here I have 70% of the population is exposed, and I could look at just a crude association, what's the risk of the outcome in these people that happen to be exposed versus the risk of the outcome in the people that happen to be not exposed, but we might, there are all sorts of reasons that the risk of mortality might be different. When we're asking a causal question, and in particular, the one that I articulated earlier, we're asking, okay, what would happen if the entire sample had this exposure assignment versus no one had that exposure. Everybody got ART versus nobody got ART for those 5 years, for example. And when we estimate these exposure effects for the joint effects of depression and ART on mortality in the WISE, with inverse probability weighting, we can get these cumulative incidence functions. And so here, this curve, this top curve, is the mortality we would expect to see in our study sample had everyone always been depressed over those 5 years and never initiated ART, versus this bottom line is the cumulative incidence of mortality we would expect to see if everybody immediately initiated ART at the start of follow-up and was never depressed over the 5 years, right? So these are pretty dramatic curves. And here's those curves summarized in a table, right? So compared to nobody getting ART and always being depressed, treating depression reduces the absolute risk of mortality over 5 years by 12%, which is huge, right? So you take this and you run off and you tell your clinic director, we need to be treating depression because we could have these huge gains in survival if we treat all of the depression in our clinic. Excuse me. There are arguably plenty of reasons to treat depression beyond improving survival, and depression is obviously something we should treat, but I've kind of harped on the idea that these exposure contrasts that we're getting with just sort of our naive, so to speak, inverse probability weighted model, these always never exposure contrasts, are a bit artificial, right? There is no world in which we would have intervened to make everybody depressed and never treat them with ART, right? So that referent group to which we're comparing our depression, remove all the depression, sort of has this artificially high mortality. And likewise, that bottom line that I showed you where we treat everyone with ART immediately and remove all the depression, that would be great, but we, as of yet, don't have an intervention for depression that's capable of removing 100% of depressive symptoms, right? So that's equally as imaginary a scenario as that top line. So the idea of intervention effects is the idea that we would like to ask the question, what would happen to mortality in our sample if we had been able to intervene and reduce the prevalence of this exposure by some reasonable amount? And you can do this with inverse probability weighting. I have not figured out how to do it, admittedly, and I haven't even seen an example. Like, the people that know inverse probability weighting better than I do say you can, but most of it's sort of easier, and I put that in quotes because the parametric G formula is not easy by any means, but it's easier to do in the G formula. So again, we're going to go back to that same example, and now rather than asking what's the joint exposure effects of ART and depression on mortality, we'll ask what happens if we compare the natural course to mortality under some reasonable hypothetical intervention on depression and ART. And so for our hypothetical interventions, I'll say we treat everyone with ART because that's now the clinical guidance. Remember, our study sample starts enrolling in 1998, so that wasn't the standard of care at that time. And then we'll reduce the probability of depression in people who are depressed by either 34% or 67%. And I came up with these numbers by looking at the STAR-D trial, which was a large randomized trial of treatment for depression. So 34% corresponds to treat everyone with first-line antidepressive therapy, and 67% responds to the intervention where you treat everybody with first-line therapy and then follow them, and if they don't respond, you intervene by changing their dose or changing their drug or some second line follow-up treatment. And as I alluded to, we'll do this with the parametric G formula. I don't have time to give a whole tutorial on it, but very, very briefly, the way that this works, to give you sort of an appreciation both of the power of this approach, but also the limitations of this approach. What we do is estimate a series of parametric models for all the time-varying covariates, the outcome, death, and then I have exposure and censoring here in parentheses because you don't actually need these two sets of models to get your estimate of effect, but you kind of need them to do some model checking. So we're going to estimate this series of models, save off all the parameter estimates from those models, and then take our study sample from that study sample with replacement, strip off everything after baseline, and then run them through a simulation predicting new time-varying covariates and outcomes with the parameter estimates that we got from step 1, and then set exposure to 1 or 0, or set exposure however we want that corresponds to our hypothetical intervention, and keep them under follow-up, so set censoring equal to 0. And then we predict a whole set of follow-up for them up through 5 years, and at the end of 5 years we look at our predicted outcomes and contrast those predicted outcomes under whatever scenarios we've modeled. In this example, just to give you an idea, we had to fit 7 different models. We tried to fit some additional models, but things sort of fell apart because there's only, I forget exactly how many women were in this sample, maybe 800 or so. And you're sort of predicting at multiple time points. And the model checking, we're relying on all these models to be correctly specified. There's really no way to guarantee that. The only thing we can do is kind of try to check. So you can see here the cumulative incidence of ART initiation in the sample, that dashed line that we observed, versus the stepped function is the cumulative incidence of ART initiation that we predicted with our models. So we have a number of these different model checking results. And in this paper, I think we were the first to also compare our exposure effects against the marginal structural model effects, because really you're heavily reliant on this correct model specification assumption, so you want to make sure you get it right. And our exposure effects from the G formula look quite similar to the curves that I showed you earlier from the inverse probability weighted model. They're much more regular steps. It's a function of being fully parametric, right? On the right is the intervention effects. This is sort of the punchline. This black line represents mortality in the cohort under the natural course that's do nothing. This big step down represents the reduction in mortality we would see if we treated everyone with ART. That was the first sort of step of our two-step intervention. And then these two dashed lines here correspond to treat everybody with ART, but then also treat them with either first-line antidepressant therapy or some sort of titrated and second-line treatment. And so you can see these, here's the table again, these risk difference estimates are much more, they're much smaller, they're much more realistic, and they're tied to the intervention that we would actually do in this population, right? And there's more of them because we can sort of simulate any number of interventions. As Betsy mentioned, there are a lot of assumptions that are required that are arguably as or more important than the model, and that would happy to have a discussion about them at some point, but it's more than I could slam into 15 minutes. And I don't know if you want me to take questions or wait until the end.
Yeah, let's do 5 minutes of questions now, and then we'll have an open discussion at the end.
We might need to pass the mic around to get the questions. Yes. And there is a mic over there.
I can repeat them. Go ahead.
Oh.
I was just wondering if the slides would be available.
So we are recording this, so it'll be online on the CFAR website, usually in a week or two, usually.
2 weeks, please.
Is it about?
Okay, turn around. Thank you.
Other questions?
I have a quick question.
Yeah.
If I want to learn about G estimation more, what should I do?
So there is a great paper by, I think Alex Kyle is the first author, that is like a tutorial on the G formula and has code as well. And then I taught myself off of Daniel Westrake's paper from like 2009, I want to say. Might have been later, but I found that one to be a bit helpful. Or I'm happy to talk through any questions with you.
This is extremely unfortunate and confusing, but G estimation is
Yeah.
totally different from the
G
G
compu-
formula and G computation,
Yeah.
which is what Katie did. It's a terminology in the causal world leaves a lot to be desired, and that's one of the most unfortunate and confusing pieces. But just to
Yeah.
if you're going to do a Google search, it's G computation or G formula, not
Yeah.
G estimation is also a causal method, but it's totally different from what Katie talked about.
Yeah. Yeah. Lori.
Sorry, hold on one second. I'll bring the mic up.
Thank you. This was helpful. On the slide where you talked about you gave what you called the informal description of how the G formula works.
Yeah.
Can you just walk through why you, use predicted, I think it was the predicted time varying covariates instead of just using what were observed? Because why do you predict them instead of using what's already there in the data?
So the key is that, and I kind of went over this really quickly, we're going to set exposure rather than having, if I just use what was there, I would just get back the observed mortality. And so I'm trying to predict, like on Betsy's slide, predict the CD4 at time 1 based on setting ART at time 0, which may or may not correspond to the exposure that the person got.
So it's essentially
that-
kind of it was almost like the counterfactual prediction of what would have
Yeah.
happened if they had been assigned. Got it.
Yeah, exactly.
For baseline, you do use what's just
Yeah.
in the data, but anything that comes after a treatment that you're hypothetically intervening on.
Yeah.
And so for this example, you were varying the effectiveness of the treatment, or you were also you were varying also the
So-
the depression treatment?
Yeah, so for this example, I varied the ART treatment assignment, which is a simple yes, no. And then I also, there's a not a wrinkle, there's a slight difference to from what I did to like some of the other G Formula papers that are in the literature, because I had depression, the probability of depression depend on the natural value of treatment. So I predicted somebody's depression, and then if they were depressed, then I replaced their depression variable based on just like a draw from a Bernoulli probability distribution that with either the 34% probability of being no or 67% probability of being no, and then let that value carry forward.
Good. Can I ask a question about,
Yeah.
I have the mic, so it's perfect. Can I ask a question about so you were setting initiation or not of antiretroviral
Yes.
therapy? And so say if you set someone to immediately start, does that mean setting them to adhere in the future? Or it's just
No.
you let them adhere you're not setting adherence, it's just they start.
Correct.
They might continue, they might not continue.
Right, yeah, so ART was an intention to treat, depression was not. So if they were
I see.
depressed at one visit, they got some depression treatment, so to speak, in my model, and then they could continue to get their probability of depression changed later, but ART was just at baseline intention to treat.
And what do you think the mechanism was in terms of depression causing mortality? I mean, you could think it's either suicide or it's not. Depression causes you not to take antiretroviral drugs or something.
Yeah, I mean, this analysis doesn't get at any of that, so this is
tell.
all purely speculation in my answer, but it could be those two things you mentioned. It could also be depression causing you to be adherent or not to other medications or health, healthy eating, healthy, other things that would influence your health.
See. Thanks.
Yeah.
So in terms of when you would use this, do you sort of see this as something that people should be considering before a trial, or this is purely for or largely used for settings in which a trial wouldn't be ethical or, really possible?
I think that the G formula is hard to fit. So this is not like your out of the box model that you should use for every day. There I would send you to inverse probability weighting, but that's just sort of personal preference based on the fitting of all 7 of those models and getting them to sort of work jointly took several months. I'm not gonna lie, it's no small task. So it's a really great approach, I think, for informing interventions or for informing decisions about funding for things where you have multiple possible interventions that you could implement, and you want to determine what's going to give you the maximum impact on whatever outcome you care about. That's where I see it more so than necessarily a pre-trial thing. There are other G methods that can get you the analog of a trial rather than the G formula. Yeah. The last one.
And then we'll move on.
Thank you. How did you address confounding in this model, and what sort of would you consider confounders, obviously using theory as you normally would and include them? Is there anything you have to consider differently in this sort of modeling with confounders?
So I think there's sort of two questions there. One is like the theoretical, like deciding what to model and what to include. And there I would stick with the standard, like what does the literature tell you? In this example, like we tried to initially include time varying drinking and smoking, but like I sort of mentioned, because you have so many models, it became very difficult and I was getting very weird results. So I had to kind of decide to ignore a couple of confounders that we thought we could kind of get away with ignoring. The way that the model addresses confounding is basically just by breaking the association between any upstream covariates and treatment assignment, because you actually like go into your set of models and assign treatment in your like model in your simulation.
Great, let's thank Katie again. Who's next? Does it matter?
Either way,
Okay, so while Aletta is pulling up her slides, I realized I didn't introduce Katie. Katie is faculty in the EPI department, also a causal expert, and she works a lot on HIV and exactly these issues of observational data and inferring causal effects. Aletta is a statistician working in the International Health Department. She works on Bayesian methods and cluster randomized trials, and has a particular focus on HIV and TB outcomes.
Thank you. Hi, everyone. Thank you for giving me this opportunity. So this work came about through the work that I've done with Dr. Lorraine Dean from the Department of EPI. We were looking at economic factors associated with HIV/AIDS outcomes, but really some of the questions related to model choice and estimation of the measures of association came about when I was doing other work in neonatal outcomes. And I'll explain why in a minute. So for this particular talk, just to give you sort of like the setting or an example that I'm interested in using to showcase the application of these types of analysis is the indicators for economic status, such as income and employment, as well as the level of education and other factors that I haven't really included here, but which may include things such as having financial difficulty and other economic indicators. And Lorraine indicated to me that technically speaking, having insurance is not really an economic indicator, but it's somewhat associated with socioeconomic status in a way. So imagine you have these indicators that could be considered interventions, so things that would help improve your health status. And in this particular case, I'm talking about what effect they may have in your clinical outcomes if you're living with HIV, such as CD4 level and viral load suppression. Now, you also have other factors like baseline factors that influence that, one of them being, the biggest one, being on treatment, as we all know. So traditionally, what we would do, if you were interested in this, whether you're looking at a single time point or multiple time points, you would consider a traditional regression model. You decide based on your outcome what is the most suitable model specification and what are your variables that you want to consider. And then you go ahead and fit a multivariable model and adjust for relevant covariates and get your measures of association, such as odds ratios, if say your outcome is binary. Now, what happened when I was doing this in the context of the neonatal outcomes was, what if we're wrong? And that all those questions led me to the applications of multiple and TMLE, which I'll talk about in a minute. So, as you can say, this could potentially lead to biased estimates if we are wrong about the modeling decisions that we make along the way. So the question I had was, we have a number of things going on here. The first one being, could this be potentially a causal question? What would happen if everybody had insurance, if everybody had, was educated, they know, to stay on medication, to adhere, all those things are sort of like causal questions. But of course, as we'll see in a minute, there are a lot of assumptions in order to come to a conclusion of a causal effect. So here we have multiple exposures too. That's another second big thing for me, is that it's not just one thing, but multiple potential interventions or potential things you could do. So if you consider that each of those interventions is a binary yes or no, unlike what Katie was just discussing, that's really not the reality. The reality is that something in between 0 and 1. But in this particular case, I'm just showcasing a situation where we're looking at a binary yes or no, you're exposed to this or not. And another thing is that these are potentially correlated, obviously. And so what is it that we could do differently from our usual traditional regression models? And then I stumbled upon multiple population intervention models as I was searching through the literature. And that was, as I said, for another application in neonatal outcomes. But basically, if we're thinking about this as a causal question, we have a parameter of interest, which is the difference between the mean outcome for the treated group or the exposed group, or those who received the intervention, and the difference between that and the mean outcome in the entire population of interest. And so the multiple population intervention models allow us to calculate this causal parameter associated with each of the interventions that is not necessarily dependent on one single global regression model. And we'll see why that is the case in a minute. But in order to do that, we have these pretty strict assumptions that have to be in place before we could make any causal statements. In statistics, we always have to rely on assumptions, and sometimes they're more stricter than the very strict assumptions. In other cases, not so strict. And I must say, as I was going through this with the HIV application, I did come across some publications which actually talked about this association between employment, for example, and HIV outcomes in a sort of opposite direction, where those people who were feeling better, so were doing better, clinically better, were more likely to be able to actually go to work, as opposed to it being the opposite. So that's kind of like a disclaimer to say, yes, I'm aware of that. I've seen that. That could be the case as well. So the first of the assumptions is the time ordering assumptions. Those of you who are maybe familiar with causal inference would be familiar with these, which means that the outcome actually happens after you have your baseline covariates in place, your gender, your age, and everything, and then the intervention or the exposure of interest happens and as well before the outcome. The second one is the consistency assumption. What we actually observe in real life is only those outcomes that are related to the treatment that was actually received. But we know there exists some hypothetical scenario where there exists a true full data set where everybody has their own treatment-specific outcome. And the treatment assignment is what treatment you get or what exposure you get is all conditionally conditional on the distribution of, conditional on the covariates. And the third one is that there's no unmeasured confounding, another strict one. So A is conditionally independent of Y given the covariates W. And then also that the probability of receiving treatment A equal to 0 in this case is greater than 0. So the probability of receiving treatment A is greater than 0. Now, coming back to a parameter which those of you in EPI may recognize this as sort of like an attributable risk parameter, or population attributable risk parameter, where you look at the treatment-specific mean outcome against the overall population mean. And so if the assumptions listed above hold, we can assume that this is equivalent to the true general population parameter. And then in order to estimate that, there are sort of two main components that have to be, the models for the two components that have to be estimated is the treatment assignment model, denoted by G, and it's commonly known as the propensity score. What is the probability of having treatment A given your covariates? And as well as the outcome model, which is the mean of Y given A and the covariates. Okay, I'm told to hurry up. So, and oftentimes in propensity score scenarios, we have this estimated by the binary regression model. So and in order to get the predicted probability of the exposure. In the multi-parameter models, here we can have the regression model for Y depends on the outcome type, but in this particular case, as I will show in a minute, what attracted me to this is the flexibility in model choice, that you don't have to be confined to one type of model. I'll skip through this quickly. The theory behind the targeted maximum likelihood estimator, which is, as mentioned before, the difference between the mean of Y given the exposure and the mean of Y for the general target population. I'm just going to hurry up and talk about the application. So Lorraine Dean introduced me to the max cohort. For this application, I just looked at the cohort, the people who enrolled between 2001 and 2003, 703 of them seropositive, and about 66% of them were on treatment, and I considered the baseline covariates being on treatment, age, site, ethnicity. There were 4 sites. And here, just for illustration, looking at just a single time point, and also to mention that there's a lot of work on TMLE for longitudinal data, which is actually more appropriate in this case. And Michael is one of the people with quite a few publications in that area. And so here, socioeconomic or economic indicators are the income was actually very closely associated with, or basically, it mirrored whether a person is employed or not, and whether they got income greater than 10,000 a year, and having insurance and education level. And then baseline covariates, as mentioned before, and then the outcome is detectable viral load. There's a very nice implementation in R of this multi-parameter intervention models, and also to mention that TMLE is not the only estimator included in that. We can talk about that in the discussion during the question and answer session. In this particular case, I just went in and tried in a situation where I define, if you remember back to the two different models that we need. We need a model for the treatment assignment and then a model for the outcome. If for the outcome, I chose in the first instance to just, actually that's not true, it's not logistic regression. I actually used the regression tree model, which is non-parametric. And then in the second choice, where now you have a number of, you could have a number of model specifications to choose from, I just wanted to see if I get different answers depending on what I allow. So what you have here are the results, which are in sort of like percentages of people who, with a detectable viral load that could be attributed to the exposure. So basically, if everybody, in a hypothetical situation where everybody was more educated, you know, what would be the viral load detection? Or if everybody had insurance, meaning they have better access to healthcare, or everybody had better income. And for the case of the recursive partitioning, where I specified which outcome model I wanted, these were the results I got. These are the results before any adjustment, before any modeling. These are just straight up proportion of people with the treatment A equal to 0, minus that from the population, the mean estimate of Y. And so if I specify the model, and I use in this case the regression tree model, which is non-parametric, this is the estimate I get. Whereas if I allow Mini-Symposium to go through and select the best estimate from the candidate models, which we can talk about during the question and answer session, these are the estimates that I get. And these are just the standard errors and the p-values associated with that. So in the discussion, quickly, what attracted me to this, besides whether my model, the causal assumptions are strictly true or not, which they should be in order to make a causal statement, but really one of the things is the unrestricted model choice, in a sense that you could, choose an estimate from a number of candidate models. And the fact that if the assumptions hold, you could actually make a causal statement, which is similar to a population attributable risk that we are familiar with in EPI. And the parameters can be tailored to the context of the study that you're looking at. And the easy implementation within R using the Mini-Symposium package. There are a lot of cons, of course, one of them being how computer intensive this can get, especially if you want your standard errors to be calculated using Bootstrap. The superlearner can also be super computer intensive, and then you have these strong causal assumptions. Otherwise, this doesn't hold. And the fact that Mini-Symposium doesn't handle missing values yet. And as mentioned before, there are a lot of references. There's a lot of work that's been done on this. And thank you.
Questions? I have a couple of questions. So, could you talk about why you chose to look at an attributable risk type effect?
Well, I think, actually, I was going to mention this. I saw on Twitter once Miguel Enan talking about why are we scared of talking about relationships being causal? And I think I'm still one of those people who's a little bit still reluctant of talking about causal effects. But I think, and if the assumptions holds for your particular context, I'm not just talking about my context, I think that we would be missing an opportunity if, say, for example, the interventions are actionable. Like if something could be done about it, why not explore stats methods that would allow us to make those statements and actually see if we could improve on or implement certain interventions. That's really why. Could giving people access, well, in this case, of course, whether it's significant or not, but could we say that if people have health insurance, they're more likely to have better health outcomes? And should we be convincing society to do something about that?
And then my other question is whether, I don't know this multi-PIM.
It's just because there's multiple interventions.
Yeah, but so I have a question about the multiple interventions, which is, do your results, for example, you can imagine a pathway where education affects the outcome because education affects employment, which affects insurance, which affects health outcomes. Is that included in your estimate for education?
Yes, I forgot to mention that. I should have actually put that in one of the slides. The fact that because there's potentially correlation, of course, these are correlated, but also in terms of the analytics, I did adjust the parameter for each intervention is calculated conditional on having, and actually this is a choice, you may or may not, but I did in this case, adjust in my Y model, adjust for the other interventions being in place. And that is why when you have strongly correlated interventions, they may cancel each other out, right, if you do that. And so, yes, I wanted an answer in a context where you look at one intervention having the others already being in play.
Yeah, okay, so it wouldn't include that pathway. It would be you're conditioning on all the other interventions and looking at what you would get for just education if it didn't affect the others.
Yeah, I think for a pathway, you would look into something like a structural equation model. I think in order to actually study those types of pathways, I haven't actually done it to try and see if I could get a causal parameter, but looking at a structural equation model where you have mediation and things like that, that's what you're referring to, right? I think that's what you would have to look into and specify what's in the path of which relationship.
Yeah, I didn't even have in mind looking at the specific pathways, just whether various pathways would be included. But it sounds like no, if you're conditioning on all the other interventions, when you look at education, it rules out pathways through those other.
Right. You can't actually quantify those, extract those paths, the other paths.
Other questions? Great, let's move on to Michael Rosenblum, my colleague in biostats, another causal inference expert, who's going to talk about targeted maximum likelihood estimation also, and he's one of the world's experts on TMLE.
I don't know if I go that say that, but
trial design.
But thank you for the opportunity to speak. And before I present on, I appreciate the great talks by the previous speakers. That's a good setup for this talk. But before I start, any general questions that you've been dying to ask about causal inference? It could be not related to this even, but I just want to make sure this is tailored to what the audience wants. Any questions on? I'm happy to try to field any causal inference questions.
I've got one, but I don't think this is the appropriate time.
You have an inappropriate question? We're game.
I've got a new biomarker. It's the change in that biomarker early in infection, if I stratify high and low, has an amazing difference in their Kaplan-Meier and survival. However, the biomarker is affected by or is associated with set point viral load. So I don't know if it's just a marker of disease progression or in the causal pathway of disease progression. And
That's a great question.
And right.
So that fits in this framework. Do you know the time ordering? So that would be one question.
So the set point
what?
viral load, I know set point viral load occurs certainly at about 6 months, 3 to 6 months after infection is where you've got your set point viral load. This new fancy biomarker is antibody breadth, measured by a new method called VIRScan, where we're looking at over 3,300 peptides. And so you look at how much your antibody breadth increases, and that starts to either plateau and go down after 9 months for the people with rapid disease progression, or it plateaus and increases for the people with slower disease progression.
And when you say disease progression?
That's time to ART initiation in a cohort from Zambia, where ART was initiated at a CD4 count of 350 at that time.
Interesting. So it's that certainly is a causal inference question where you have exposures over time that you need to adjust for. So that would fit within this, potentially fit within this framework. But you need to, it does illustrate, first you need to know the time ordering of things so you can rule out, things can't, in principle,
Go backward.
cause into the past. And then you might be interested in what if you were to set, or what's the causal effect of that biomarker being higher or lower? The adjusting for different confounders measured over time. So yeah, it's a good question. So that potentially, I'm not saying that much useful here, but it potentially does fit into the framework of what we're talking about. So that's a good question.
I would just say, if I understood part of your question correctly, it's you want to know, does A cause B or does B cause A? Is
A, this new biomarker, is the change in that a marker of disease progression, or is it causal disease progression?
So I think that's a question that you can distill that to. Does the causal arrow go this way or does it go that way? There's no silver bullet for that. You have to go and collect fine-grained data about the time scale, and there's
So we have time varying data.
So we have data over time on this particular biomarker. We show that it goes up, then plateaus. In the people who have rapid disease progression, it goes down. In the people where they've got slower disease progression, it stays flat or goes up. However, that biomarker, if I'm looking at it, is associated with set point viral load, where the biomarker goes, it goes the same way with disease progression. So I know set point viral load is the biggest driver on disease progression that exists. Which makes me think that, and I can biologically understand or make up a reason why it's just a marker of, because I'm killing my T cell help for my antibody response, and therefore it's just a marker. But it would be great if it was a variable which you could change, say through a therapeutic vaccine, to then help your potential outcome without medication.
Yeah, it's a great question.
Can I weigh in just real quick?
Yeah.
So it sounds to me like in terms of viral set point, that you're actually asking whether or not this biomarker is on the causal pathway between set point and disease progression, because then essentially set point affecting this biomarker, whatever, I think you said antibody breadth, the breadth of antibody diversity, I guess, and then in terms of disease progression, right, versus whether or not it's just a marker that lies off the pathway.
Correct.
And so in that case, it is a causal question, but it gets very closely to a mediation question that Betsy brought up, I think, earlier.
Okay.
Let's come back to this if we have
Yeah.
time.
Yeah, it's a nice question. It's hard, as Betsy said. That's pretty hard. But it's a really good question, and definitely, I think, definitely worth pursuing and looking at what can your data say or not say about that. Good. So I'll be presenting on a general method for estimating the impact of treatments over time or exposures over time. In causal inference, we treat them synonymously, exposure or treatment. But the key is that they're measured over time and that you may have confounders over time as well. So when you're, as was mentioned by speakers before, when you're in that situation, standard just fitting a regression model is not going to cut it. Then you need some more advanced method, and some of the more advanced methods for estimating effects of these longitudinal interventions or time-dependent interventions or exposures. There's inverse weighting, there's G formula, and another method is this targeted maximum likelihood estimation. So there are three approaches. They're all aiming to measure, estimate the same thing. So they're all different techniques you could try, but they're all going after the same, or they can all be used to go after essentially any of these kind of things you're trying to estimate, the impact of time-dependent exposures or treatments. And there's trade-offs between them. Personally, I'm biased because I work on targeted maximum likelihood, but I can just give a quick ranking of those methods. I think and I've used all the methods, so it's not like I'm a pure, you should only do this or that. But I think that in terms of pros and cons, I'd say that the weakest method is the inverse weighting approach. That has probably the most drawbacks, though I've certainly used it in the past. And that one is, though it's the easiest probably to implement, so that's kind of one of the trade-offs. But if you can, I'd say it has the most drawbacks. In the middle, I think there's this G formula approach. I think that's preferable. And then there's a target maximum likelihood tries to get the best of both worlds. The motivation for it is just trying to get the best features of inverse weighting and the G formula approach. Those inverse weighting and G formula they model different components of the distribution of the data. Inverse weighting is modeling the probability of the exposure given a person's history up to a certain time point, and it's just focusing on predicting exposure given history. The G formula approach is not modeling that. It's modeling the probability of the outcome given history or probability of covariates given history, and that's why it's kind of burdensome. You have to model a whole bunch of, you model everything, or at least all these covariates and the outcome. So, target maximum likelihood ends up, you're modeling both of those, so that to some extent you're modeling both of those. But it has a property called a double robustness, which means that if the models that you would use in inverse weighting, if those are correct, then the estimator is consistent, meaning it does converge to the causal effect that you're going for. But if those models are wrong, but the other models, the models used in the G formula, if those are correct, then it's consistent. It needs just one set of those models to be correct. So it's a little bit more, it's more robust to your models being wrong. So it has that advantage. But the high level feature of it is trying to get the advantages of both of those inverse weighting and G formula methods.
Can I just interject that robust
Yeah.
does not mean robust to any of the assumptions you need to interpret things causally? I think robust it sounds in some ways like a silver bullet, but it's really just about statistical modeling choices and not at all about the assumptions of no unmeasured confounding and whatnot.
Exactly. So the key assumptions for all of these causal methods, I mean, there are some exceptions, but we're not talking about today, but generally you need an assumption like no unmeasured confounders to be able to estimate a causal effect. And that's a hard, first, the data cannot tell you about that. It's not something you can look in your data and analyze it and it will tell you you have unmeasured confounders or not, because they're not there. They're unmeasured. So it's something you have to know from outside knowledge. And that's what basically making an assumption or being able to come into a problem saying, all right, we're pretty sure we have all the confounders or most of them. That's what allows you to go from correlation to causation, or it's one of the things you need typically. So that's the hardest, I think, of all these assumptions, the no unmeasured confounders. Data can't tell you, and probably you will have some, honestly. I mean, you're gonna have some, but you just hope maybe they're not overwhelming everything else that's going on. So those assumptions there's no way around them. The only way, I mean, there's instrumental variables, another approach that also has its own set of assumptions you need, but that's something you might do with unmeasured compounding. So all the methods we're presenting today they have potential to work but they all require this baseline level of no unmeasured confounders, I'd say is the main thing you need. So what I'll present, and I'll try to be pretty quick because we're near the end here. This is joint work. Well, this is really Claire Ruberman's work. So she's a PhD student who I advised, and she's presenting her PhD thesis. Her defense is tomorrow, 10 a.m. in W2008. So I'm just going to give a few slides from her work that she said I could present here. It's almost like a teaser for her defense. I'm not going to tell the answers. I'm going to try to leave it as a cliffhanger. So you go to the defense to find the answers. But it's really, she did amazing work on this. I'm very proud of what she did. And it's a joint work with Craig Hendricks, and it's funded by the CFAR and Gates Foundation. This is our 11-month-old baby, Ashan. I just want to put that up there. This is a little bit to tell if I fall asleep partway through here from lack of sleep, just roll me aside and move on. But the research question that Claire is answering is, what's the protective effect of maintaining a certain level of blood concentration of PrEP drug, tenofovir? And that's an important question. So there have been many randomized trials of pre-exposure prophylaxis for HIV prevention. They're varying low. I mean, if you take the evidence as a whole, highly effective at preventing HIV. Though some studies give a much higher protection, some studies show lower levels of protection. And the goal for future trials is to try to understand or just in general, to try to understand what blood concentration level should be the target. What level do you need to have a high level of protection against HIV? So we looked at, we had two studies, the Partners PrEP and the Voice studies. So these are completed randomized trials. And the challenge is that, there are a few challenges. These are studies where people were randomized to PrEP versus their placebo arms also. But you're not randomized to a drug level of blood. You're just either getting the pills with the real tenofovir based PrEP in it or placebo. So it's not randomized who has high concentrations or low concentrations in their blood. And so we basically took these trial data sets. We focused just on the treatment arms. So that's where you can have blood, and they had some blood concentration measurements. But it wasn't on everyone, and it's just at the visits when they come in. So there are a couple challenges. I mean, the fundamental one is that it's not randomized when people are taking who's adhering to the medication and who's not. It could be that people who adhere more are also having higher risk behaviors. And so if you just look at the people who have high blood concentrations when they got measured, and look at their probability of HIV infection versus the people who had low blood concentrations, their probability of HIV infection, it could be a very distorted view of what is the actual protective effect. It could just be that people who are highly adherent are having less exposure. I mean, when you just look at the raw data and you just look at those associations, they're very strong. When you look at the people who had high adherence or had high concentrations, very rare that you have any infections. So it definitely happens. There are some, but a very low probability of infection compared to people who had, if you have high concentration versus if you have low. But the question is that causal? How much of it is causal and how much is selection bias, essentially? So the goal here is to try to remove distortion caused by selection bias and adjust for HIV risk factors as much, at least the ones that were measured. There are added challenges to this analysis, which is why I'm very impressed that Claire, what she did. One of the big challenges was that we didn't have concentration data on everyone. It was essentially a case cohort type of study design or data set, in that everyone who seroconverted, we had concentration measurements on them, and also just a random subset of people who did not seroconvert. We have concentration measurements from them. This is all based on stored blood samples. And so we're trying to use that, so that adds one layer of challenge on top of this. But I'll just tell the idea, what our goal, I'll skip a bunch of things, but I'll show this, that if you look at concentration measurements over time, so you're getting concentration measurements at 6-month intervals, 6-month visits. People come in for HIV test. They're also getting, based on a blood draw, what's the concentration of drug in the blood, and it's really all over the place. It's not flat. Sometimes it is, but it's really can go up and down between visits.
Each line is a patient?
Each line is a patient, yeah, sorry, I should have explained that. Each one, so these are showing patient trajectories over time, but it's really just measurements at 6, 12, 18, and 24 months of log concentration of the tenofovir-based drug. And so there are a lot of people who just have, this is the limit of detection, so it's undetectable. And a lot of people here, but then there are a bunch of people, there's a smaller subset who are detectable. Basically, this is, if you're above this level, it's consistent with daily dosing in the last week or so. But then there's a lot of up and down between. Yes?
And is seroconversion measured at every visit?
Yeah. Yeah, seroconversion measured at every visit as well. And on the left, you have cases, meaning that means people who seroconverted, and cohort is people who did not seroconvert. So based on this longitudinal data set, we're trying to look at, so what can we say about the impact of different levels if you're able to maintain. So the question, we boil this down to the question of what is the protective effect of maintaining a continuously high concentration or continuously low concentration of drug on infection. We try to look at different thresholds as well to see what the data could tell us. And we use targeted maximum likelihood. Since I just have a few minutes left here, we use targeted maximum likelihood as the estimation technique. And as I mentioned before, it's going after exactly the same thing that you would with inverse weighting or G formula. There is software that will do it for you. But generally, you probably want to talk to someone who has already has done an implementation with it. It's not the most user-friendly software. It's really good software. It's quite impressive and powerful what it can do, but you need a little bit of background to, or just someone who's used it before to help you just get a foothold in there and try it out. But it has good properties in the sense that one is this double robustness property. It's robust to some models being incorrect. Yeah, so I'll just, I don't want to tell the results, but there was some I'll just give the teaser that it did not, some things did match with prior analyses. So the prior analyses did not consider the time-dependent nature of concentration. They just used the first visit concentration. And then it turns out you miss a lot if you do that. And if you do control for the time-dependent nature and you adjust for risk factors over time as well, that you get, there's some answers that were different in I think, an interesting way. But I don't want to steal the thunder from Claire, so I'm just going to stop there. But I generally do recommend this technique. In principle, there's nothing harder about it than with the inverse weighting and G computation. It really is merging those two ideas. But it's, and in terms of things like computation, it is a little more, it is similar computational demand as the other methods. But nowadays, I think of that as not really much of a constraint, since computation is so cheap and fast. So, yeah, so that's all. I'll summarize that.
Questions?
No, go ahead.
No, go for it, please. Go after.
I have a sort of general question, a little bit like Oliver, but so I'm working on developing a proposal with others around looking at prep and comparing on-demand prep versus daily prep.
That's a great one.
In Thailand, and trying to see, you know, who takes which, what kind of recommendations we might make for when people should switch from one regimen to another. Is this like a good approach for doing that type of work?
I'd have to get some more information, but at a high level, yes. Yes,
Yeah.
it depends on what kind of data do you have. What,
Well,
you have longitudinal data?
It's going to be
That's what you mean.
longitudinal, yeah.
Yeah, we should talk about it. And, yeah. But I mean, in general, these techniques, if you need longitudinal data, and you need to have the confounders, you need to have as many confounders measured as possible so you can adjust for them. That's the general requirements.
I was just curious if you could elaborate on something you said prior to the start of your presentation about how you preferred G formula over inverse probability weighting. Because I tend to think the opposite sometimes, just because of the difficulty of fitting the G formula. So I was just kind of curious.
So, well, yeah, I can tell about that. I can even, my top preference would be this.
Yeah.
This one, and this one doesn't require, it does avoid some of the having to fit models for all the covariates given the past. So it does this, I didn't want to get into the details of it too much, but it does a sequential regression approach, which is a little bit different from what G formula does. So you're able to, you don't have to specify a model for every, say like at the visit 18 or say visit 12, kind of in the middle, what's the probability of having unprotected sex given the past? You're not modeling that directly, at least. So this one I think avoids partially that issue. But in terms of your question about G formula, which is essentially modeling the outcomes and covariates given history versus inverse weighting, which is modeling the probability of exposure given history. The big downside to inverse weighting is that the weights can be unstable, especially if you have lots of time points. That often you end up with this problem that you're dividing by the probability of following a particular regime for a bunch of time points, and you're multiplying probabilities together, 1 over probability, multiplying those together, and it can basically give you something very unstable. So that's, especially when you have more than a few time points, it's especially disadvantageous to use inverse weighting. Now I just want to say I've done this. I definitely used it, and at times in this case with 8 time points. So I'm not saying that it's kind of, so it's stuff that I think the field has learned a little bit over time about some of the downsides. So I've definitely done it, and it has some advantages, and it's mostly the ease of implementing it. But the other thing is that even when the models are correct for inverse weighting, even when all the models are correct, it still can be very inefficient, meaning the confidence intervals can be very wide compared to G formula. If those models are correct, then it's efficient, meaning the confidence intervals are tighter. So it's that's one of the reasons that inverse weighting, even when everything is pristinely perfect, which you never really get anyway, but even if models were all correct, it's really giving you wider confidence intervals than sort of if you go from the G formula approach. So those are some downsides. And I've definitely, and I know from experience from using it and trying different techniques that I think it has the more weaknesses than the other approaches. But yeah.
I just want to play devil's advocate, and I'm sort of agnostic as to which one is better in general, but I would say that one thing to consider when choosing between these strategies is whether you think you know more about the probability of exposure given the past or the probability of the outcome given the past. And that in particular, people make the argument that if exposure is a treatment where you visit your doctor decides whether to give you ART or not, it might be very feasible to actually learn about what the probability of a doctor prescribing ART is. You might be able to ask the doctor, what covariates do you look at when you decide to prescribe ART? For this type of patient, would you or would you not? And so that, I think, would be a real advantage of the inverse probability of treatment approach if it's something that you can learn about with more confidence than the outcome regression. And then there are settings where the opposite is true. So I think that, and that folds into ease of use. So that is not a statistical argument at all. That's about what information is accessible and what models are easy to think about and fit.
It's a really good point, and I'd say that, and I've heard others make that argument, and there's substance to it. I would say that when you use, I think the optimal is to try to combine both. So if you think you understand the probabilities, you're better able to model the probability of exposure given the past. You can do that with one of the double robust methods, and then just do kind of a very minimal model for the other part. So you can, but it is a good point. And ease of use should not be underestimated. I mean, in practice and how, so that is a real thing. And we're working on trying to make tools to bring them all to everything, make it easier to use, but that I can't say that it's all there yet. So yeah, it's a real thing to think about, unfortunately.
We've gone 2 minutes over time, so I think we should wrap up now, and thanks everybody.